عليكم ورحمة الله وبركاته. أهلا وسهلا بيكم في أول حلقة من الإبيسود بتاعت ميت ذا إكسبرت. إن شاء الله تكون مع أستاذنا الأستاذ الدكتور عبد الفتاح الأصفر، أستاذ أمراض القلب والأوعية الدموية واستشاري مرضى القصور القلبي وزراعة القلب وزميل جامعة تورنتو بكندا. أستاذنا الدكتور عبد الفتاح، نتشرف جدا إن حضرتك معانا النهاردة، وإن شاء الله تكون بداية موفقة ونستفيد من حضرتك كلنا وكل شبابنا هنا يستفيدوا من حضرتك. أهلا وسهلا بحضرتك.
شكرا. Thank you very much, Usama. Thank you very much. It's my pleasure.
It's our pleasure also. We are very happy having you with us. Today we are going to discuss the SGLT2 inhibitors, which one of the very important drug in the field of cardiology, especially this year. We will discuss the subject in a simple way that can suit every young cardiologist. And we would start by the theory behind the SGLT2 inhibitor. Dr. Fattah, what do you think give this drug such importance today?
Yeah. Regarding SGLT2 inhibitors, these are the fantastic medications today and the highly effective medication today in the treatment of heart failure. Regarding the mechanism of action of this medication, there are something that we know very well, and there are something that is theoretical about the mechanism of action. What we are sure about is that these medications are glucosoric drugs. They potentiate the excretion of glucose in the urine by inhibiting the SGLT2 receptors in the proximal tubules of the kidney. So they promote diuresis by promoting glucose excretion, and also they promote sodium excretion as well, not only glucose but sodium as well, by inhibiting another mechanism, which is the sodium hydrogen exchange type 3 mechanism as well. This isoform or these receptors in the proximal tubules keep sodium in the body. If we block this NHE, it's called NHE type 3 in the kidney, they promote also diuresis by promoting the sodium excretion. They both excrete sodium and excrete glucose in the urine. This is what we are sure about. There are many theories also surrounding the mechanism of action, that these medications also increase the uric acid excretion as well. So they decrease uric acid in the blood as well. Also, we found that these medications might also potentiate the erythropoietin action. So they might induce hemofiltration as well, besides improving erythropoietin secretion. So they might increase the hematocrit, might increase the hemoglobin, which may also help the mechanism of action for heart failure. Also, we found that these medications also might have anti-inflammatory effect. Also, these medications also, there are theories, animal theories and animal experiment, that they block the sodium glucose exchange isoform type 1 in the heart. And this helps to prevent fibrosis and prevent stiffness of the heart as well. So it's a multiple mechanism of action surrounding the action of these fantastic medications.
Okay, so it's not just the diuresis effect of such a group of drugs, not only the diuresis effect, it has many other action that can protect and prevent further events.
Yes, exactly. Very difficult to explain all this beneficial effect by only glucosoric effect.
Okay, so regarding the safety of such a group of patients of drugs, do you think it's safe to use such fantastic medication as you describe them, especially in frail elderly patients suffering from heart failure?
Simple answer: it's a very safe medication. They are very safe drugs. Most of the landmark studies in the field, either in diabetes or in heart failure, the side effect profile was very comparable to placebo. But there are some tips and tricks which surround the use of these medications. 100% of these medications will increase the incidence of UTIs and genital infections, because simply they increase the glucose in the urine, and this will be a need for promoting the infection. And most of the trials in diabetes and heart failure, there was signal toward this increase the incidence of UTIs and genital infections if compared to placebo. But most of these infections were not clinically significant. They were mild to moderate infections, which did not translate to discontinuation of the medication. So you should be very selective in very high risk patient for developing infections, like a very elderly patient. When I say very elderly, I mean if you are going by age, then I'm speaking about those who are above 80s or even 85. If we are going by frailty and independency, I can see people who are women who are bedridden, poor hygiene. Those are the people who you might be scared by using this medication to avoid the severe genital tract infection. Severe genital tract infections, especially gangrene, genital gangrene, which you call it fournier gangrene, is very, very rare. And it just records in the literature, and it's very immunocompromised, bedridden, poor hygiene, elderly, female. So you can be very selective in individualizing this medication for use in those category of patient only. Otherwise, in terms of infection, genital and urinary tract infection, the medications are, I can say, are safe, not only safe, but very safe in terms of numbers in all the trials. If you are asking me about other safety profile, I can speak about other safety profile.
Yes, please, if we can
for example, the kidney function. Yeah, the kidney functions. Who are these medications are the second beneficial effect after improving the heart failure events is the renal protection. These medications are very effective in terms of renal protection. They decrease the decline in the eGFR in diabetic patient, in non-diabetic patient, in heart failure patients, and in patients with chronic kidney disease. Even patients who have already chronic kidney disease, those patients, if we use SGLT2 in them, we decrease the likelihood to have end-stage renal disease, the likelihood of dialysis, the likelihood of death from kidney problems, and the likelihood of cardiovascular problems in those patients. Patients with chronic kidney disease. But the tips and tricks of this patient, the eGFR, what the lowest limit of eGFR that I can use this medication safely. Actually, most of the trials now, you can use them down to 20 eGFR. And even you can continue using it down to 50, down to 15. So even if we go below 15, you can stop. But even if you are expert in using them, you can stop them only if the patient enter in dialysis. So the lower limit of use can be 20 or maximum 25 in some literature. So this is regarding the kidney safety endpoints. Regarding the other safety issues like fractures, like amputations, in heart failure trials, we didn't face any problem with these side effects. Only canagliflozin in diabetic studies, they have some reports about fractures, osteoporosis, and amputations for peripheral arterial disease. This is very, very rare reports in SGLT2 in general, and if they are present, they are with canagliflozin, not with empagliflozin or dapagliflozin, which you are using in heart failure.
Okay, but regarding the end-stage renal disease, we know that there's an ongoing trial about the use in the end-stage renal disease patient on dialysis. Before these trials, in your experience, we can use such a group of drugs in patient on dialysis?
I didn't use them, and they still are waiting for that. But our recommendation clearly today, in my practice general, I don't use them if the EGF. I didn't start them. I don't start them if the EGF are below 20, and I don't stop them till the EGFR comes comes down below 15. So still
Okay.
I don't use them if the AGFR came down below 15. But the most
And
important
regarding,
message that I want to convey, don't panic if there is some dipping in the EGFR and the creatinine after the initiation of these medications. Just be patient. It will repick again and will improve in the coming few weeks to few months. So don't panic at all.
okay.
Like always we see for ACE and ARB. When you use ACE and ARB in heart failure patients, you might have some decline in the EGFR. I can accept up to 30% decline, 40% decline. And if the patient is well monitored and I'm seeing him frequently, even I can accept up to 50% decline if I'm following the patient meticulously. So don't rush and stop the medications once you see some dipping in the creatinine or the decline in the EGFR.
Okay, and regarding the follow-up, the intervals of following up the creatinine or the GFR in patient on such group of drugs, do you, in
I
your
can tell
experience,
you
do you?
clearly, I can tell you clearly, you don't need to give special monitoring appointments for this per se. If you are up titrating the medicine of heart failure, you give the follow-up and the monitoring according to your schedule for up titration. You don't need
Okay,
to have a special affair of seeing the patient after 1 week, after 2 weeks, after 3 weeks. This medication don't work like this. Just give them
okay,
time, don't worry. But if you are seeing the patient frequently for other medication up titration, this is a different story. Because the beauty of this medication that they are very simple in titration. They are only single dose. You start them and you don't need to increase the doses. It's 10 milligram dapagliflozin, 10 milligram empagliflozin. This is the approved effective dose in heart failure therapy. So start them and look to monitor other medications like sacubitril valsartan, like ACE/ARB, like beta blocker, which need frequent monitoring because of the multiple step titration process with these medications.
okay. I would like to go back for the urinary tract infection. Would you recommend doing a routine urine analysis for checking up the even a subclinical urinary tract infection, or just
No
by the
recommendation,
symptomatology of
no
the patient?
recommendation at all regarding routine screening for UTI. If the patient gets
Okay,
symptomatic by any way, but gets symptomatic, had fever, has whatever any symptom or sign for UTI, then you start treating this infection as any UTI, as any genital
okay,
infection. If it's candida, which is common, you treat candida. If it's UTI, non-specific, you treat UTI. The majority of these infections will clear up without discontinuation of the medication. If the patient is high risk, immune compromised, very poor hygiene, then don't use the medication on those kind of patients.
okay. But in our regular patient that we face every day, even if the urinary tract infection occurred, you insist on also on continuing the drug. Treat the
Yeah,
urinary tract infection.
you treat
Okay,
the infection and continue
okay,
the medication.
okay,
Because risk benefit ratio is clear. It's a very beneficial drug if you compare the risk. This medication
mm,
decrease the mortality, decrease the heart failure hospitalization, heart failure events. They improve the kidney. They have a magic effect on the kidney. They also have
okay,
decrease hyperglycemia to some extent. So they are additive to treatment of diabetes. There are also they decrease the weight. They might
okay,
tackle the metabolic syndrome. So there are many benefits using these medications which cannot be compared at all to the risk. So you can't say I will stop all these medications for the elderly. No, the elderly have a higher event rate, and so they will have benefits. Those who are having a higher
okay,
event rate will have more benefit. Even we found in sub-analysis that patients who have more dipping of the creatinine, sorry, more dipping of the kidney function during the treatment with these medications have a major benefit in terms of endpoint of heart failure. So I can tell you
okay,
the more dipping means the more benefit on the other side. So
okay,
deal with this medication in this concept. Don't rush on and stop and they deprive the patient of the benefits. Of course, you are
Okay.
clinician. You could have great sense regarding the patient who might have complication or side effect, like any other heart failure or cardiac medication.
Okay. And regarding the protection this group provide for the patient, would you recommend using this group in heart failure or the population of the heart failure that are a moderate probability for heart failure with preserved ejection fraction, especially those who are obese or have an atrial fibrillation?
This medication are the first ever medication that showed benefits in terms of reducing the hard endpoints of cardiovascular deaths or heart failure hospitalization in patients with heart failure. We have now very robust data from two big studies, the Mirror Preserve study for empagliflozin and the Deliver heart failure study for the empagliflozin. These are about, I think, about 11 to 12,000 patients, most of the studies, and the benefits are very consistent, very comparative, very comparable. There is a reduction of the endpoints by about 20% on both 18% in the Deliver and the 21% in the Emperor Preserve. The data are very consistent. Most of the data came from reducing the heart failure events in patients with HFpEF. This is why this medication indication now have been upgraded in our Saudi heart failure guidelines. We are the first to upgrade the indication of this medication to class 1A early 2023 with the Saudi heart failure guidelines. I was part of the committee writing these guidelines. And then with the ESP just a few weeks ago, when they published update for the 2021 heart failure guidelines, and they recommended this medication as first line class 1 indication for HFpEF. This is the first time to have indication after Lasix, after diuretic. If the patient is not yet diagnosed and is maybe high likelihood of having this medication, having HFpEF, I will simplify the answer. If he is diabetic, he is eligible. As we are done.
Okay.
If the patient is diabetic, he is eligible to have this medication as a first line. Means he is diabetic with even one risk of having HFpEF, like obese, like AFib, like high BNP, even to milder degree. Then this is the first, you should think first on SGLT2 inhibitor as a first line, even before metformin. Even before metformin. Okay. If he's not diabetic, then you should see how much of the risk. Like if the patient just have obesity, atrial fibrillation, but his age is still 40, his BNP is still very low, then you can wait some time. But you screen him yearly by BNP. This kind of patient who are not diabetic and the BNP is not high, but they have clinical risk factors like obesity, like atrial fibrillation, is see them every year, do BNP every year. This is the best thing to do for him. You will discover HFpEF very early and start SGLT2 as early as possible. Once you are sure that we are in the stage of HFpEF, because this is the beauty of this medication. The earlier you start, the benefit on the long run.
Okay. And any preferences, Dr. Fattah, for the EMBA versus DABA?
This is a very common question, and the simple answer, I can say no. Both of them are the same. The data in the trials, in the landmark trials, are very consistent, very comparable. Even if you find one study, the defect in DABA, you will find the other study defect in EMBA, and so and so. Yani for example, the EMBA study, which was the earliest study, the benefit were more in the favor of EMBA if compared with DABA in the DECLARE study. When it comes to DABA HF and the Emperor reduced, you will find the benefit more in terms of cardiovascular deaths with DABA than EMBA. When you do the meta-analysis and you mix all the data together, you will not find the signal of preference at all. They are the same. Okay. But when it comes, for example, to kidney benefit, you will find some preference for EMBA over DABA on the kidney benefits, especially in the Emperor reduced study. When you look to the IMBA kidney and the DABA HF, sorry, the DABA CKD, very comparable. The benefits are almost identical, symmetrical. So the population, if you find some difference in some studies, look at the population. Most of all, the population will be different. So in terms of trials, there is no big differences between the two medications. But in terms of some small studies, like observational studies here, you might say some people, oh, IMBA is better than DABA. We don't consider these. The benefit of IMBA over DABA is the dose also, because you have the 25 milligram dose, which is beneficial in patients with diabetes, of course, but not for heart failure.
Okay, but regarding the urinary tract infection, also there is no difference between the IMBA and dapagliflozin.
No difference between all, despite in the IMBA reduced, they stated clearly there was increased incidence of non-significant urinary tract infection over placebo. One statement, the conclusion was clear that there was higher incidence of urinary tract infection in the IMBA over placebo, but was not translated to drug discontinuation. This statement was not in the DABA HF study.
Okay, and my last question is the many physicians are suspicious about the current booming, as we can see in especially in the recommendation regarding the prescription of such medication. Do you think there is any conspiracy theory behind this booming effect, especially in this year?
This is a very good question. If we are going with the conspiracy theory, we will not use evidence-based medicine at all. So the biggest achievement in heart failure management over the last 30 or 40 years was the clinical trials. Clinical trials is the booming for the treatment of heart failure. All clinical trials. Once we started clinical trials with its ACE inhibitor in late 80s with the consensus and solved it, and then we have this big progress in heart failure management, and this progress has been topped up by these magic medications, this SGLT2 inhibitor. It's so impossible to be conspiracy theory with all these benefits in different trial settings and in different patient profile and with different huge number of institutions all over the world and huge number of patients, almost more than. We are now almost achieving 200,000 patients in clinical trial with this medication. A huge number of trialists and scientists. So different committees which have no bias. So it's very difficult to say conspiracy theory about the use of this medication. We are heart failure experts, and they are using this medication every day. And we see our patients. Of course, this is not the best judgment, but just an example for use.
Okay, so that's an effect that we touch every day during our practice with our patients.
Of course.
Okay.
Yeah.
اوكي دكتور عبد الفتاح ثانك يو فيري ماتش فور يور تايم. نشكر حضرتك شكرا جزيلا، ونتمنى يعني نكرر ان شاء الله مع حضرتك، نتعلم ونستفيد من حضرتك دايما. ونشكر حضرتك شكرا جزيلا على وقتك. ولو حضرتك تحب في يعني 2 minutes كده، لو في مسج صغيره لحد بالنسبه لليوز اوف SGLT2 inhibitors in general، يعني نستفيد من حضرتك في a small or short message.
The best thing you serve your patient, heart failure patient or chronic kidney disease patient or diabetic patient, is to be very aware about this medication. You can save lives, you can improve quality of life, you can decrease the coming of the patient to the hospital, so you will enjoy good quality of life by using these medications in different aspects of benefit, as I said before. So the message, please be aware by everything about this medication and use them. Don't deprive your patient if they are eligible for use of these medications, as any other heart failure medications in our field of heart failure.
Okay, well, thank you, Dr. Fattah. Thank you very much, and hope we will see you soon, إن شاء الله.
شكرا أسامة، شكرا جزيلا على الحضور، وكتر ألف خيرك حبيبي.
شكرا جزيلا حضرتك. شكرا. عليكم السلام.